What's going on, guys? It's Dominic from Revive Therapy and Wellness, and today I want to go over a very simple topic, but it's a topic that I feel like we have a million questions on, and it's basically what I do with all of the patients when they come in for their first time consultations at any of our offices nationwide, and this is going to be geared towards males. So I'm going to be doing a female talk very similar to this, but this specific one is all about the male body. So male hormone replacement therapy, or what I like to call male hormone optimization therapy, it entails two things, and a lot of people, this is where you lose right here, because a lot of people don't realize that they're missing a whole half of hormone optimization therapy. So I'm gonna go through it. It's super simple. It's gonna be a little bit of more of a lengthy video, but you're gonna get a ton of information from it. So I really do hope you guys watch the whole video. The first, I guess, component to hormone optimization therapy that most people think of when they think of it is testosterone, right? So the male starts with testosterone. So you have testosterone here, and then the other part of HRT that most people forget about is gonna be growth hormone, okay? So growth hormone is here. And I'm gonna leave that for now, but I just wanted to put it on the board so you guys understand what we're gonna go into after I go through the testosterone. So testosterone replacement therapy is the most common type of hormone replacement therapy for males, and it entails really three things. And the three things are testosterone, and then HCG, and anastrozole. HCG is a lot of people don't necessarily know the difference between hormone replacement therapy or optimization therapy versus cycling. So this video is strictly for people who are replacing their hormone levels as they get older. So the average 40-year-old guy who comes into the office and realizes that their testosterone is not what it used to be, and they're getting heavy, they're losing their muscle, they can't eat what they used to, they don't have time to play with their kids at night because they're so tired. This is geared towards that patient. This isn't geared towards bodybuilding. This isn't geared towards people who cycle anabolics. This is literally strictly for a hormone optimization patient. So HCG, what is it? Why do you use it? A lot of people that go to their primary care physician for HRT aren't getting HCG. And HCG holds a pretty key role in hormone replacement therapy because it keeps the natural testosterone on as you're going through this stage of life. So for example, if you come to the office, we do your blood work and your testosterone level is a 400, okay? It's lower, it's not horrible, but it's still there. You still have 400 level. So our goal as a clinic is gonna be to take you from 400 to 800, 900, okay? And by doing so, we incorporate the HCG because once we start giving the body synthetic testosterone, it shuts its natural testosterone off. And what that means is, say you came in with that normal 400 level and we give you testosterone without HCG, now your level is gonna be 0 or very, very low because of that synthetic use of testosterone. So instead of basically bringing you from 0 to 800, now we only have to bring you from 400 to 800 and bridge that small gap. So HCG is a key element in HRT for long-term use, okay? Anastrozole. Anastrozole is something that it kind of really depends on how you're gonna take your HRT. And when I say that, it's very simple. Either intramuscular injection, pellet therapy, subcutaneous injection, and that's pretty much all we use here. You can use troches or creams for men too, but they tend to not be as, effective, I guess you could say. So what we're gonna do is we're gonna go through the two most common ones that we use in our office, and it's gonna be sub-Q injection and IM injection. So if you're doing an IM injection of testosterone, anytime you take testosterone as a male, you're going to naturally increase your estrogen levels, okay? So what that means is if I give a patient 1 ml of testosterone or 200 milligrams of testosterone, there's a really good chance that your estrogen level is gonna raise out of the normal for a male. And we don't want that. What estrogen does in a male is it's gonna give you excessive water retention, mood swings, irritability, high emotions. Lots of things that people would associate to roid rage actually are estrogen based, okay? So that's something that a lot of people don't know, and it's something that you need to understand, because if you do go to your primary care physician, most of the time they're just gonna give you testosterone. So you're not gonna get either of these two things, okay? And what that means is the therapy isn't gonna be effective and it's gonna have a lot of issues long term. Elevated estrogen levels can cause hypertension, anything. It's horrible. Lots of things that you don't really want to happen can be avoided by utilizing these two key components in HRT. So remember, HCG is going to keep your natural T, so testosterone, on. Anastrozole is going to keep estrogen levels low. Now, too low can be a negative effect too. So too low, so a low estrogen level can actually give you the same side effects as low testosterone. So this is a really, really important thing to monitor. I would guess that the average level we see in a non-hormone replacement therapy patient is between like 27 and 32, maybe to 40. So I like to keep that as a normal. So I think that's a great normal level for estrogen in the male body. Now, going into the different reasons of testosterone, the different ways to inject testosterone, you have sub-Q and you have IM. These are the two ways that we're going to do a lot of our therapies in our offices, and the reason is because they're just the most effective, especially for men. Now, these two things I would say you're going to deal with are going to be the reason why anastrozole comes into play. So if you're going to do a sub-Q injection, sub-Q doesn't aromatize estrogen as much as IM does. So for instance, when I first started HRT, I did my HRT IM, okay? And what that meant is I would give myself a shot in the muscle, in my glute, 1 cc a week. I would do 1 milligram of anastrozole and 1,000 units of HCG weekly. It worked great, I loved it. I just hated needles. So what I did is I ended up switching to sub-Q injection. And now that I've switched to sub-Q injection, by doing so and taking my anastrozole how I was taking it, my estrogen levels actually were too low, which means that I don't aromatize my testosterone as much by shooting it subcutaneously. So now that I'm doing sub-Q injections, I'm not taking anastrozole anymore because it's not aromatizing into estrogen in my body. So it's a great way to get off of estrogen if you don't really want to take estrogen. There are certain negative side effects of anastrozole long term. It has to do with bone density, a lot of different things that just aren't really healthy long term. So that's something that I really do recommend. I really like subcutaneous injection. Now, obviously, it's for, you can't do this if you're a bodybuilder. You can't do this if you're taking extreme doses of testosterone because of the simple fact that, you can only put so much testosterone under your skin before it starts to get irritated. So I microdose my testosterone. I do it every single day. So I take a sub-Q injection of testosterone of 0.2 cc's every single day, Monday through Friday. And my levels are very neutral. I really like the way I feel. That's kind of one of the biggest changes that I've seen since I've switched from IM to sub-Q. Now, you can do the same thing IM. You can take shots multiple times a week. So for instance, a lot of you, if you're doing HRT through your primary care physician, you guys are going to be doing 1 shot a week or even 1 shot every 10 days. And that's not that effective because of the simple fact that there's different types of testosterones, and no testosterone in the body lasts 10 days. Now, their half-life does. So for instance, from going from 200 milligrams at one point all the way to 0, yeah, it's in there. But do you really want to feel that? Because what happens is you get this. You take your shot on Monday, your testosterone spikes up like this, and then for the rest of the week it goes like this, and then by Saturday you're back down to nothing in your body. No one wants to feel like that, okay? That's not the best idea. So you have a Monday shot, and you have, by Friday, this is how you feel. So the true way to do this is to take, if you're taking a longer ester like a testosterone cypionate, you want to do a Monday, Thursday shot, okay? And what that means is by the time this starts to go down, you're taking another shot and you're giving yourself a pretty even plateau across the board, okay? So that's going to make you feel much better as well. But necessarily, it's definitely necessary to do that. So the next thing I'm going to do is I'm going to go through the different esters of testosterone. There's really 3 different kinds of testosterone that are prescribed legally in the United States. One is going to be testosterone cypionate, one is going to be testosterone enanthate, and one is going to be testosterone propionate. Now, they also do make a blend of all 3 of these testosterones, which is pretty effective too if you want to get really, if you want to feel the testosterone faster. I actually like to do this specifically when I am treating people who have no testosterone when they come to me. So if a patient has no testosterone when they come to me, so prop is short for propionate, E is short for enanthate, and C is short for cypionate. So if I get a patient that comes into the office and they see my physician in the office and they have a testosterone level of 100, 110, it's horrible, right? They feel terrible. And my goal as the office is to basically give them a feeling of feeling better as fast as I can. So in order to do that, what I'm going to do is I'm going to give them some type of a propionate or a blend, because propionate has a 1-day half-life, right? So if you take propionate, you need to be taking propionate 3 times a week for it to be effective in the body. So that would mean a Monday, Wednesday, Friday injection. Okay, so that would mean if you were taking 1 cc a week, you would need to split that 0.33 cc's 3 times a week to get the effective dose and taking propionate the right way. Now, if you're taking enanthate, you can do the Monday, Thursday, and if you're taking the cypionate, you can do the Monday, Thursday. Both of these are very similar, enanthate and cypionate. I think collectively they have about a 10-day half-life, which means that, you know, every 4 days you want to retake the shot to make sure that you're getting that perfect normal level in the body. So that's really the gist of the HRT as far as testosterone goes. I would say the average male that we like to see, their testosterone between the ranges of 800 to 1,000, as long as all of their other levels are normal. So their estrogen is under control, you know, ALT, AST levels are under control, you know, their PSA isn't terrible. All of those things play a pretty huge role in this. So if you guys are looking into getting hormone replacement therapy, 3 things you really want to watch for are your hemoglobin and hematocrit levels. Those are going to get elevated as you take hormones, especially testosterone. So giving blood monthly, things like that are super important to stay healthy while you do this. Your liver enzymes. Liver enzymes usually don't get too high from taking injectable testosterone, especially at hormone replacement level doses. But if you're getting into other things that you can do with the right symptoms like oxandrolone and things like that, you really do need to watch your liver enzymes. And TUDCA is a great pill or a great oral supplement to kind of keep those at bay while you're taking oxandrolone. And then the last thing you really want to look at is your PSA. Now, prostate-specific antigen is what I mean by that, even though the PSA isn't a specific test, which is kind of confusing because the name says it is, but it really isn't. So if you have an elevated PSA, there are things that you can do to lower it naturally. Well, not naturally, but with help. So a new trial that just came out that is amazing, just got FDA cleared, is finasteride at 5 milligrams and daily dose Cialis at 5 milligrams. And those 2 things together combined can actually substantially decrease your PSA levels in the male. But that being said, if you do have an elevated PSA level, it is something you need to get checked and make sure it's not anything serious before you start hormone replacement therapy. So like I said, guys, liver enzymes, hemoglobin and hematocrit, and your PSA levels are things that you really want to take a look at before you start experimenting with any type of hormone replacement therapy. Now, you guys probably think this is it, right? This is all you have to think about. Testosterone, HCG, anastrozole, the different types of testosterone, how to take it, how I said you can do it intramuscular, subcutaneously, but that's really only half of HRT, and that's the truth. A lot of you guys are missing the whole boat. There's another half of HRT that actually, in my opinion, is just as effective or maybe even more effective than this side, and that's growth hormone. So there's a million different things that you can do to elevate growth hormone in the body. Now, I always tell patients this when they come in, when they're asking questions, and the first question is gonna be, what's the best for me? And that really depends on your age, it depends on your budget, because the true best thing for anybody really when it comes to elevating your growth hormone levels in the male body is gonna be taking real growth hormone. But not everyone is allowed to do it. Not everyone has the blood markers to show that you need growth hormone. And truthfully, it's not always the best case depending on your age. And I'll explain that. So there's really 2 ways that you can stimulate growth hormone in the body. And 1 is by taking synthetic growth hormone, and 2 is by taking growth hormone releasing peptides. So you're gonna ask what those are. There's literally tons of them. Ipamorelin, Samorelin, CJC, GHRP6, GHRP2, and all of those things work really well. And the problem is that you're gonna notice as you're gonna see younger people trying to take growth hormone releasing peptides, and they're gonna tell you that they didn't work for them. And they're probably right. And the reason is because the body only secretes what it needs. Growth hormone has a fail-safe. So if your body, your pituitary gland is secreting the proper amount of growth hormone that you're supposed to be having or supposed to be taking in, it's not gonna make more. And that's what ipamorelin does. It stimulates the pituitary gland to secrete more growth hormone. But that fail-safe will say, hey, listen, we're good, we don't need any more. We have enough, we're done. So younger people don't get the same benefit of ipamorelin and samorelin and those things like older people do. So for instance, my patients in the office that are over the age of 60 and have a really low IGF-1 level and a low growth hormone level, when we put those patients on one of those growth hormone releasing peptides, and I'll write them down in a second, those patients see amazing results from it. They sleep better, you know, all of those things start to happen because they need it, right? Now, when you're dealing with synthetic growth hormone, there is no better result that you can get. Synthetic growth hormone long-term is gonna be the best thing that you can do. And the reason being is because it's literal growth hormone. It's not stimulating to release, you're just literally giving growth hormone to the body. Now, there's 2 things that, all right, so let me go over here real quick. So you have ipamorelin, you have samorelin. Sorry, my handwriting's terrible, but you get the point. You have CJC, you have GHRP 6, and you have GHRP 2. Okay, so all of these are going to be growth hormone releasing peptides. So another great thing about these is they actually started to make blends, okay? And that's a really cool thing that compounding pharmacies have started to do. Tailor-Made Compounding Pharmacy does a great job of this. Sorry, Wells, you guys just don't do the same things that they do. But they'll make a combination of an ipamorelin, CJC, IGF-1. Oh, I'm sorry, there is IGF-1 that can go in here too. And I'll get into that in a little bit. IGF-1 is a very complicated peptide, and I don't really like giving it out to many people, and I'll explain that. And then you have obviously just HGH, right? HGH is the synthetic version of growth hormone. So HGH is going to be, you know, the fountain of youth. What everyone says is the best of the best when it comes to anything. Now, these two things together are going to be true hormone optimization therapy, okay? And I'll explain you why right now. So testosterone, when you take it, it takes a cell and it increases a cell, okay? So that's gonna give you muscle size, that's gonna give you those energy levels, that's gonna give you all the things that you really wanna feel as you're getting older. The instant gratification, you would say, for male HRT, okay? Now, growth hormone is gonna do kind of the opposite. So that's gonna deal with cellular, not cellular growth, but it's going to be cellular agenesis, so creating new cells, right? So you're creating new cells with growth hormone and you're blowing cells up with testosterone while increasing energy levels, sex drive, and all of that. So together, you know, if your goals are to gain muscle, what's better than creating new cells and at the same time increasing the size of those cells with testosterone? You see what I'm saying? So together they do well, alone they do great. I really wouldn't recommend taking growth hormone without testosterone, whereas I would say that if you couldn't afford this side of it, this side of therapy is still gonna give you great results. All right, going back over here, you have your HGH, you have your ipamorelin. HGH, a lot of people say, well, how much is HGH? HGH is expensive, okay? Real HGH from a compounding pharmacy, or not from a compounding pharmacy, actually, it's not able to be compounded yet. So it's from generic pharmacy. It's pricey. And I always tell patients this when they come in, if you can't commit to this long-term or lifelong, then it's not something you wanna start, okay? And the reason being is because when you start taking HGH, just like when you start taking testosterone, your body's gonna probably start to shut down its natural production because it notices that it's getting it synthetically. So if you're gonna take HGH, make sure that you can afford to do it long term, or you can actually cause more harm than good to your body, which is why I always recommend starting with something like this to make sure, one, the patient can afford it, two, the patient likes doing it, and three, the patient is patient enough to wait for results. Testosterone, you can start seeing results in 4 weeks, even sometimes sooner. Growth hormone takes months. So if you have a patient that is, you know, ready to feel good tomorrow, this might not be the best thing to start them with because of the simple fact that it takes a long time to start seeing the results. Now, what are the results from growth hormone? I told you it's gonna make new cells, but what does that mean? So what does that mean? In life, right, you have stages of growth and then you have stages in death. So when you're younger, what you're doing is you're in a huge cellular agenesis state, right? So you're growing, you're making cells faster than they're dying. So you're getting bigger, you're getting stronger, you're getting taller. All of those things are happening, which is really, that's growth hormone. Growth hormone is doing that, or just the natural phases of life. Now, when you get to a certain age, what's gonna happen is that's gonna turn backwards. Cells are gonna start dying faster than they're gonna be regenerating. So at that point, that's when you start dying or decaying or getting older, okay? And that's when growth hormone can come in and really make a substantial difference in your life. So your hair, your skin, your nails, all of those things that you start to notice changing as you're getting older, growth hormone can really help change, as well as internally. So when it comes to just sleeping better, energy levels, things like that. Those are the things you notice first from growth hormone before you start seeing the physical changes. And that's why I think together, there's really nothing better than doing both of these. Now, I guess the next question is gonna be, I would say, with growth hormone and ipamorelin, somorelin, CJC, GHRP6, I kind of touched on the topic of, what age is good for both. And the truth is you can't really know, you don't know anyone's story until you take their blood. But like I said earlier, an older person is definitely gonna see more results from taking these peptides than a younger person. And then an older person will also see great results from taking HGH. But a younger person is gonna see more results from taking synthetic HGH than they are from these peptides because of the simple fact that shutoff doesn't work when you start flooding the body with synthetic HGH. It kind of just overlaps the shutoff, and the pituitary gland can't stop the fact that you're taking in all that synthetic growth hormone. Now, the problem there is that most young people can't take HGH. They're not candidates for it. which unfortunately it sucks, right? But at the same time, it's not really meant for that. It's not meant to be used like that. So I truly believe that the ipamorelin, samorelin, CJC, GHRP6 blends, or even by themselves, are going to be great things for anyone over the ages of 50, 55 who really want to see that, that next level of change once they start HRT, or really just because they want to stop that aging process. So I know a lot of you guys, that was a lot of information. I know I talk kind of fast, but this is a really important topic, and I'm going to go into more detail on all of these things as I make more of these videos. This is the first of many, I'm sure. So the main key points that I want to take away from this are there's two different types of hormone replacement therapy, okay? Hormone optimization therapy consists of two different parts of the body. Now, testosterone from the gonads, growth hormone from the pituitary gland. Each of these do different things. So, right, I would bet that 90% of people watching this video thought that this video was gonna end right here, okay? Just right here. So you take your testosterone synthetically, you're taking your HCG to keep your natural testosterone on, so you just bridge the gap. The anastrozole is used to keep estrogen levels low when needed. Sometimes you don't need it. Some people don't need anti-estrogen at all. Intramuscular injections, I recommend twice weekly just because of that, like I showed you guys, that curve, right? So instead of getting this curve of taking it once a week and going like this and then feeling like shit again and then taking it and feeling like shit again, you're gonna take it twice weekly so you eliminate that little nasty dump in the middle. You'll get a little one, but it's not gonna be big. Now, sub-Q injections daily, this is exactly what I do in my own personal therapy. I take my shots every day, Monday, Tuesday, Wednesday, Thursday, Friday. I microdose, sub-Q, and I get this perfect level, right? See, it doesn't even move. It just stays straight. So that eliminates any type of estrogen spikes. That eliminates all the different side effects that you can have from taking testosterone like this, which you don't want. Now, most people on HRT from their doctor are feeling just like this. So if you're going to your doctor and you feel like this, just ask him, say, hey, listen, do you mind if I split up my dose twice a week? And he should have no problem with you doing that. Then going over to the growth hormone side, this is really, this topic could be talked about forever. There's so many different things I can go into on this. But the ipamorelin, samorelin, the CJC, the GHRP6, I'll talk about the IGF-1 last, are gonna be the things that basically you're going to use as peptides to stimulate your pituitary gland, which secretes growth hormone, okay? Those things work very well, like I said, for older people. So if you're an older guy and you're really looking at trying to reverse the signs of aging and reverse health and reverse all of those things, this is a really good thing to start or look into. And in doing this, it's not going to break your bank. Now, if you can afford to take growth hormone and you have the proper blood markers to show that you need it, great, that's awesome. But most people kind of stay into this range, and truthfully, I like this range better. I think this range is good for older people. Now, IGF-1. So this is the last thing I'm going to talk about in this video, and it's going to probably be something that's very controversial, but it's something that needs to be said. So growth hormone turns into IGF-1 in the liver. Okay, so the end product of HGH is IGF-1, right? So IGF-1 is way cheaper than HGH. So why doesn't everybody just jump to taking IGF-1? Well, the truth is IGF-1 is the only thing that's really still linked to causing cancer in the body. So that being said, most people don't want to take straight IGF-1, synthetic IGF-1, one, because it's very difficult to get. There's a couple compounding pharmacies in the country that make it, and it's, the codes or ICD-10 codes for it are little kids who basically can't grow. But that being said, it is something that I still want to talk about. So everyone says, well, why can't I just take IGF-1 instead of taking HGH? And the truth is IGF-1 does not do the same things that HGH does. There's a lot of different things in this amino acid chain that IGF-1 won't touch. So the anti-aging and those things, the skin, the hair, the nails, the sleeping, all of those things you're gonna get from HGH, because HGH, because it converts to IGF-1, doesn't mean that IGF-1 is HGH, right? Does that make sense? So when you convert something into something else, what the end goal isn't always the same chain of peptides as HGH is. So all of those anti-aging aspects from HGH, you're not gonna get from IGF-1, you're gonna get more of the growth factors, which is the name IGF-1. It's insulin-like growth factors, okay? So that's something that's really important to understand. And that's really where people get the term that, oh, growth hormone causes cancer. If you have cancer, it's gonna grow everything in the body. There is some truth to that, but the real thing in there that causes the cancer is the IGF-1. So like I said, guys, it's a very sensitive topic to talk about because there's probably could be millions of questions asked just from that and just saying, oh, well, that's not true or this and that. But the truth is that is true. And it definitely can cause cancer. And it's definitely something that you need to really know your family history and to get even like maybe a CGX, PGX screening on before you do any of these things, just to make sure that you're a candidate and you don't have that gene in you. But I hope you guys like the talk. Like I said, it's a ton of information, but I really feel like it's needed. And I really feel like this part of hormone replacement therapy is overlooked all the time. And if you do these things together, you can see a huge significant difference just in the way you take it. We'll go through dosing, protocols, all of those things next, but this is just the introduction to HRT for men.